Hello, Dr. John.
Hey, how you doing? Can you hear me?
I'm good. Yes, doctor. I am good. I'm good. And you? How are you?
Good. How you doing?
I'm good.
Yeah, I'll be with you. I'll be with you in a few minutes.
Yes.
I'm just posting now in the, I'm posting now on the Facebook
All
group,
right.
which I'm going to have you learn how to do so you can help me. What do you think of that?
Yes, that's a very good idea. Very good idea.
Well, it'd be great. It might evolve to a paying position.
Yes.
But we'll talk later about that, okay?
All right, Dr. Ben. All right.
Okay. Yeah, it's crucial that I post on all the neurosurgical groups so that people know it's there. You've seen how I try to promote it, right?
Yes, doctor. I've seen.
Yeah, you've seen the post on Facebook, and
Yes.
you may have
So,
got emails too.
I got a bit. I had some difficulties logging into Facebook.
Okay, well, we'll just try and keep our fingers crossed. That's all we can do. Are you the first presenter, Zolo?
I guess I'll be the first, given that on the flyer I'm the first. So if there's no problem, I can be the
Oh,
first.
well, it doesn't matter. We're not. It's not
Or
ready to
we just
start yet. It's not ready to start yet.
Yeah, okay. Or we just have the presentation from the presentation on duret hemorrhages. I think he's going to be cool. Then we follow with my presentation and then Dr. Kabulo.
Oh, okay. So we have you, and then Durette's hemorrhages, and then Dr. Hulo,
Yes,
right?
yes, doctor.
Okay, you're scheduled for first, right?
Yes.
Okay, as usual, it was going to have to be a balancing act with your bandwidth. Hello, Galaxy 250.
Hello, how are you, Dr. Bennett?
How you doing? Good to see you.
Thank you. My name is Dr. Kelvin Nemaire from Zimbabwe.
Yeah. I see. All I can see is Galaxy A50.
Okay. I just joined today.
Oh, that's okay.
Yes, I'm actually a fellow in Turkey.
Oh, are you in Turkey now?
Yes, I'm in Turkey right now. So Dr. Kavulo is my friend. He told me about it.
Oh,
So
good.
Yes, so he's the one who invited me.
Yeah, I've seen you at other ones too. I've seen the name. I've seen it.
Yes. Thank you so much, Dr. Bennett.
Yeah, okay. Okay, let me just get Zolo, are you there? Okay.
Yes, I'm okay, doctor.
Okay, I guess you have your video muted, right?
Yes.
That's okay. Well, I got your presentation. We can practice it here if you want.
All right.
Let me open it up here because you sent it in a different file type than I'm used to. Hold on. Yeah, let me open it up first. Okay, maybe that's the best thing to do. Just we'll rehearse here. Okay, there it is. Okay, I'm going to screen share it.
Yeah, I think I've renamed myself now.
Oh, okay, there we go. Okay, you see the presentation, right, Zolo?
Yes, I can see it.
Okay, now we need. I need to make it bigger, right?
I think it's all right like this. All right.
Is this okay, or you want to do something else?
You might just remove the column so you cannot see the next slide.
Oh, okay. Let me see how you do that. Oh, there we go. Like this, right?
Yes, all right. Perfect.
Yeah, and then let me see if I go forward here at the bottom left, or I just click on the screen to go forward, right?
All right.
Yeah, there we go. Okay. Now I'm trying to go back. How does it go back? There's usually an option. How do you go back here in case we need to go back?
I think it is down. It is down at the where you are right now. Somewhere there.
I'm trying to think.
There's nothing there.
Yeah, there's no option here. Where is the option to go back?
Forward. This is forward. Try to click on the.
No, I know that's forward. How do you go back?
Try to click on the right side of the screen.
Oh, the right side of the screen.
Yeah. No, it's
No, that's going in the. Okay. Oh, okay. Now I see. Okay.
It keeps on going forward.
Okay, let me just go back to the very beginning here.
Yeah, it's good.
Okay. So what I can do is I minimize it. When I want to minimize it, hold on. Okay. No, I can't see where to go back.
What about your keyboard?
Oh, keyboard, what do you do?
Try to. Is there something like next page or?
Oh, wait, maybe there's a. Okay. I know there's an arrow here. Oh, I see. Wait a minute. I'm pushing my, okay, now I'm trying to go back.
This is forward.
Oh, there we go. There we go. Yeah, all keyboard. Yeah, yeah, that's cool. Okay, I got it.
All right. All right. All right.
Zolo, I may look like I'm stupid, but I'm not.
No, 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 no. Everything needs some moment of adaptation. Everything needs some moment of adaptation.
Yeah. There's Marco. Hey, Marco.
Fine, thanks.
You're lecturing on acute hydrocephalus. Hey, Marco, how you doing?
Oh, I'm finding out. Thanks. And you?
Good. I had an Italian neurosurgeon write to me today that wants to present.
Wow.
Let me see what his name. Let me see. Let me get the name. Hold on. Antonio, let me see if you know him. I'm going to share my screen with you.
Okay.
Hello, Dr. Marco.
Hey, Zulu. How are you?
I'm fine, doctor.
Do you know him, Antonio Musio?
No, actually not.
Okay. Well, I don't know where Ferrara, Italy.
Oh, yeah. He's in the north central Italy. Yeah.
Oh, near north of Bologna, right?
Yeah, correct. Right.
Yeah, you're in the Milan. Yeah, that's not too far from you, right?
Oh, I think 3 hours and a half for car.
Oh, okay, that's a long way in Italy, right?
Yeah, I don't think in the United States, right? Distance are more.
It's
longer.
nothing. It's nothing. 3 hours, nothing. That means it's close.
Okay, John, I apologize since now because I can stay just 1 hour because I have the night shift today.
Oh, okay. No problem. No problem. Here, let me make sure I'm working this.
Ben de yiyin çok sağ ol. Eyvallah.
Okay, let me get the. Hold on. Acute. Okay, are you ready, Zolo? Okay.
Eyvallah. Güle güle.
Are you ready, Zolo?
Hello. How are you? Welcome.
I'm going to unmute you, Zolo. Having trouble unmuting you. Can you unmute yourself, Zolo, please? I'm trying to unmute you, but it's not going through. Zolo's is a bandwidth challenged area, and I think that's why I can't really unmute him. Zolo, can you hear me? You probably can, but he can't unmute himself. Come on, we've done it before, Zolo. You may have to come back in. You may have to leave and come back in. Okay, I'm trying to unmute you from your screen too. You may have to leave and come back, Zolo. Why don't you leave and come back? There you go. Okay, there you go. You can hear me now, right?
Yeah, I can hear you.
Okay, let me mute everybody else, and then I'll introduce you, Zolo, okay?
All right, doctor.
Can you put your picture on briefly when I introduce you, and then you can go off it? There we
I'll
go.
just
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3. Good afternoon from Miami Beach, the home of the Neurosurgical TV studios. Today we're lucky to have a med student from Cameroon. I believe he's fifth year, Zolo Ivan. He's going to be talking about acute hydrocephalus, and we're going to be followed by a few more presentations. Let's first introduce the panel. Hello, Marco. Welcome.
Meloni, okay, and the audio is here. I'm a consultant neurosurgeon in Gravenona, north part of Italy.
Good. Welcome, a frequent contributor to this channel. Welcome, Marlo. And Kelvin, welcome. Please introduce yourself.
Thank you so much, Dr. Bennett. It's my pleasure to be here. I'm Kelvin Nemaire from Zimbabwe, a consultant neurosurgeon, currently a fellow in skull-base, majoring in neurovascular and neuro-oncology in Turkey.
Very, very welcome, Kelvin. And maybe we can hear of what your experiences in Turkey in a formal presentation. And also a friend of Dr. Kabulo, who is going to be presenting in a couple of hours. So, okay, Zolo, welcome and thanks for accepting the challenge. And it's all yours. Okay, Zolo, you're muted there.
sorry. All right. Is it better now?
Yeah, it's good. It's good.
Yes. All right. I'm Zolo Ivan, a CTM medical student from the University of Buea in Cameroon. I am a member of the Association of Future African Neurosurgeons, and I'll be the one to present today. So thank you very much for being there to everybody, and Dr. John, we can proceed.
Okay, let me share the screen. There we go. Okay.
All right. So the lecture of today is acute hydrocephalus, presented by Zolo Ivan, me, a member of Association of Future African Neurosurgeons, medical student from the Faculty of Health Sciences, University of Buea in Cameroon. So next slide, doctor.
Okay. I'm trying to use my keyboard. It's not working. Okay.
Voilà.
There we go.
Okay, so you are going to follow this plan. You are going to have an introduction. You are going to speak about epidemiology. Then you are going to look at the pathophysiology, and then we shall see how to make the diagnosis and the management. Then you are going to speak about the prognosis, and you are going to have a summary, and I will give you my references.
Next slide.
Yes, doctor.
Okay.
Okay, so the term hydrocephalus is derived from two words: hydro meaning water, and the cephalus referring to the head. So hydrocephalus is a condition in which excess cerebrospinal fluid builds in up within the ventricles of the brain, and they may increase the pressure within the head. So CSF has three crucial functions. The first thing is it acts as a shock absorber for the brain and the spinal cord. The second one, it acts as a vehicle for delivering nutrients to the brain and removing waste. And then the last one is it flows between the cranium and the spine to regulate the changes in the pressure within the brain. Next slide, doctor. So here we have two diagrams. One is showing us the ventricular system, the different ventricles. We have the lateral ventricles, we have the third ventricle, we have the foot ventricle, and we have the different connection between them. So on the second one, we have the pathway of the CSF flow. So you see it moves from where it is being produced and circulates through the different ventricles and passing through the different foramina. And it is very important for us to have this in mind, because if you need to understand what hydrocephalus is all about, you will need to understand this circulation and all this physiology. Next slide, Dr. Ben. So here again is another diagram summarizing the production and circulation of the CSF through the ventricular system. Next slide, Dr. Jen. So hydrocephalus may be caused by impaired CSF flow, impaired CSF reabsorption, or excessive CSF production. So in obstruction to the CSF flow hinders its free passage through the ventricular system and subarachnoid space. Thus, and this can cause an increase in the intracranial pressure. So hydrocephalus can also be caused by overproduction of CSF, that is from the choroid plexus, due to maybe a papilloma, a villus hypertrophy. Next slide, doctor. Hydrocephalus can be congenital or acquired later in life. So it can also be associated with birth defects, including neural tube defects and those that result in the aqueduct stenosis. So causes of acquired hydrocephalus include infections. We have brain tumors, we have traumatic brain injuries, we have intracranial hemorrhages, and acute hydrocephalus occurs over days, while subacute hydrocephalus occur over weeks, and chronic hydrocephalus occurs over months. Next slide, please. Based on its underlying mechanism, hydrocephalus can be classified into communicating, non-communicating, normal pressure hydrocephalus, and benign external hydrocephalus. And it is important to note here that cerebral atrophy, focal destructive lesions lead to CSF increase in on the central nervous system, but they are not classified as hydrocephalus. They have a different subset. Next slide, please. So now let us try to see the different types that we have mentioned in the previous slide. So communicating hydrocephalus or non-obstructive hydrocephalus occurs as a result of either overproduction of the CSF, defective absorption of the CSF as a result of damage to arachnoid granulation, or venous drainage insufficiency, and this causes diffuse ventricular dilatation. So in a non-communicating hydrocephalus, which can also be called obstructive hydrocephalus, here we see CSF flow is obstructed within the ventricular system or in its outlets to the arachnoid space, and this results in impairment of the CSF flow from ventricular to the arachnoid space. So in the diagrams I show you in the beginning of the presentation, you saw the pattern, the CSF flow. So if there's any disruption here, if there's a problem at the level of the outlets, then we speak about non-communicating hydrocephalus. If there's obstruction, then we speak about non-communicating hydrocephalus, because there's actually a lack of communication between the ventricular system, which is like actually a pipe. So if there's any problem at any level in the pipe, like for example an obstruction, then we speak about non-communicating hydrocephalus, because the ventricular system is not communicating. Like there's like a barrage. That's why it's also called obstructive hydrocephalus. So it is mostly seen in intraventricular or extraventricular mass occupying lesions, and these lesions, it is present when these lesions apply pressure on the ventricular system. There's when you can also have some sort of obstructive hydrocephalus. This next slide. If the foramen of Monro obstruction may lead to the dilation of one or enlarge enough both lateral ventricles. So if there's an obstruction at the level of the foramen of Monro, given that it is kind of a communication with the spinal cord, there's going to be dilatation of, first of all, the ventricles that are immediately after it. So you are going to have the dilatation of the different ventricles, and that's how it's going to go backward. So the aqueduct of Silvius is normally narrow, but may be obstructed by a number of genetic or acquired lesions, and lead to dilatation of both lateral ventricles as well as the third ventricle. So A fourth ventricle obstruction leads to dilatation of the aqueduct as well as the lateral and third ventricles. This is seen mainly in Chiari malformation. The foramina of Luschka and the foramen of Magenti may be obstructed due to congenital malformation, and this is being seen, for example, in Dandy-Walker malformation. Next slide, doctor, please. Dr. John. Okay. So, normal pressure hydrocephalus is a form of a chronic communicating hydrocephalus, and it rarely occurs in patients younger than 60 years. It is so-called because of enlarged ventricles and intermittent increase, but often normal CSF pressure. Thus, the name normal pressure hydrocephalus. And at night, there might be some intermittent elevation of intracranial pressure in some individuals, and it is characterized by a triad of symptoms, which is dementia, apraxia gait, and urinary incontinence. Next slide, please.
Next slide.
Yes, doctor.
Okay.
So benign external, another form of hydrocephalus that we mentioned in the beginning, benign external hydrocephalus is defined as benign enlargement of subarachnoid space in infants. It is a self-limiting CSF absorption deficiency leading to some dilatation of subarachnoid spaces, raised intracranial pressure with mild to moderate ventricles dilatation, though sometimes they might be normal. And this is a type of communicating hydrocephalus, and most often resolved by the age of 1 year. So that's why it can also be called a benign. Next slide, doctor. So congenital hydrocephalus, as the name implies, is present in infants prior to birth, and the most common cause of congenital hydrocephalus is aqueductal stenosis. Other causes include neural tube defect, arachnoid cyst, Dandy-Walker syndrome, and the Arnold-Chiari malformation. In newborns and toddlers with hydrocephalus, the head circumference is enlarged rapidly and soon surpasses the 97th percentile. That is when we can now call it some sort of enlargement of the head compared to the normal population. And since the skull bones have not yet firmly joined together, bulging, firm anterior and the posterior fontanelles may be present even when the person is in an upright position. And in about 80 to 90% of infants with spinal bifida, they develop hydrocephalus. Next slide, please, doctor. About so now I think you're speaking about the epidemiology. So about 1 to 2 in every 1,000 newborns have a hydrocephalus, and the rates in the developing world may be higher. Normal pressure hydrocephalus is estimated to affect about 5 per 100,000 people, with rates increasing with age. The pool incidence of congenital hydrocephalus is highest in Africa and Latin America, and lowest in the United States and Canada. And the incidence is higher in low and middle income countries than in high income countries, and those are the values, or those are the estimations. So while likely representing an underestimate, each year nearly 400,000 new cases of pediatric hydrocephalus will develop worldwide. Next slide, please. John.
Oh, I'm sorry.
The greatest burden of disease falls on the African, Latin American, and the Southeast Asian regions, accounting for 3/4 of the total volume of new cases. The high crude birth rate, greater portion of parents with post-infectious etiology, and higher incidence of neural tube defects all contribute to a case volume in low and middle income countries that outweighs that in high income countries by more than 20-fold. Global estimate of adult and other forms of acquired hydrocephalus are lacking. So a global effort to address hydrocephalus in regions with the greatest demand is imperative to reduce disease incidence, morbidity, mortality, and disparities of access to treatment. This next slide, doctor. Incidence is same in male and female unless for Vickers-Adams syndrome, which is an X-linked hydrocephalus, which is an X-linked hydrocephalus with aqueduct of sorry aqueduct of severe stenosis having male predominance and it has a male predominance, meaning that it's an X-linked condition. So normal pressure hydrocephalus also has a slight male predominance, and hydrocephalus has a bimodal age curve. One peak occurs in infancy with various causes, and the other one in adulthood. Adult hydrocephalus represents 40% of total cases of hydrocephalus. Next slide, please. So hydrocephalus ventricles or the subarachnoid space. In a person without hydrocephalus, CSF continuously circulates through its ventricles and the spinal cord, and is continuously drained away into the circulatory system. So alternatively, the condition may result from an overproduction of CSF. So we can either have a problem with obstruction, or we have a problem with overproduction of CSF. So from a congenital, I mean, we can have a problem. You can have hydrocephalus can occur as a result of overproduction, and from a congenital malformation blocking normal drainage of this of the fluid. I mean, normal flow and normal drainage of the fluid, or from complication of head injury or infections. So, for example, in somebody having meningitis, there can be some problems with the arachnoid villus. So the hydrocephalus is not going to be properly reabsorbed, and also some sequelae of the infection can lead to some sort of stenosis of the different passage through which CSF will pass. So all this can contribute into causing hydrocephalus. Next slide, Dr. John, please. Okay, so compensatory mechanisms may occur through transventricular absorption of CSF and absorption along nerve root sleeves, resulting in enlargement of the optic nerve sheath. This is important to understand, because all this will somehow determine what we are going to observe in the clinical presentation of the patient. So the temporal and the frontal horns dilate. The temporal and the frontal horns of the ventricles dilate first, and is usually asymmetrical. This may result in elevation of corpus callosum, stretching, and eventually perforation of the septum pellucidum, tightening of the cerebral mantle, or enlargement of the third ventricles downward into the pituitary fossa, thus causing pituitary dysfunction. And also there's some sort of dorsal the dorsal midbrain compression leads to Parinaud syndrome, which is characterized by paralysis of the up gaze, pseudo-arguell Robertson pupils, convergence retraction nystagmus, and there's eyelid retraction, thus leading to some sort of setting sun sign. This is like some sort of like hallmark of hydrocephalus in children. Next slide, doctor. So compression of the brain tissue by accumulating fluid and the skull eventually cause neurological symptoms such as convulsion, intellectual disability, and epileptic seizures observed in hydrocephalus. These signs occur sooner in adults. And fetuses, infants, and young children with hydrocephalus typically have an abnormally large head, excluding the face, because of the pressure of the fluid because of the pressure that the fluid causes, which causes the individual skull bones to bulge outwards and at their juncture points. So it's obvious that given that in children the sutures are not yet well formed. So if there is some sort of increase in pressure from within, this is going to cause an outward bulge of the the different bones of the skull. Next slide, doctor. The elevated intracranial pressure may cause compression of the brain, leading to brain damage and other complications. If the foramina of the fourth ventricle or the cerebral aqueduct are blocked, CSF can accumulate within the ventricles. This condition is called internal hydrocephalus, and it results in increased CSF pressure. The production of CSF continues even when the passage that normally allow it to exit the brain are blocked. So this will lead to fluid that builds inside the brain, causing pressure that dilates the ventricle and compresses the nervous tissues. Next slide, doctor. Compression of the nervous tissue usually results in irreversible brain damage. If the skull bones are not completely ossified, as we already mentioned, when the hydrocephalus occurs, the pressure may also severely enlarge the head, as we see in the image that is just beside. And the cerebral aqueduct may be blocked at the time of birth or may become blocked later in life because of tumor growing in the brain stem. So it can be acquired or it can be congenital. Please, next slide, doctor. This is an image of the ventricular system. You see how how it is dilated, and beside is the sun setting eyes in a child with hydrocephalus, and also see how the head is severely enlarged. Next slide, please, doctor. So, having seen the pathophysiology of hydrocephalus, let us now speak about the clinical presentation of the patient. So, how will they present, and what determines the presentation of the patient? So, the presentation of the patient is determined by one, the age of the patient's age. It's clear that if there's a hydrocephalus in a child, like maybe an infant in whom the sutures have the sutures are not yet well formed, is going to be the presentation is going to be different from hydrocephalus occurring in an adult where the sutures have already been consolidated and well formed. So it depends on the patient's age, the underlying cause of the hydrocephalus, the location of the obstruction, the duration, and the rapidity of onset. And the symptoms in infants include poor feeding, irritability, reduced activity, vomiting. Next slide, please, doctor. Next slide.
Can you see that?
Symptoms, we have already seen the symptoms in.
Is this the right slide, Solo?
I think infants. Now let us see symptoms of the mental capacity leading to some. No, can you just go backward?
You want to go? I'm sorry. You want to go back a slide?
Yes, one slide back.
Okay. That's.
No, you went forward.
Okay, as usual.
Use the keyboard.
I'm not used to this platform. I'm going back forward. There's no option to go backwards.
Use a keyboard. The keyboard.
Oh, I'm sorry. Okay. You're right. You're right.
Okay. Good.
Tell me when. Is this it?
Yes. This is a slide. Good.
Okay.
So we said that there's going to be slowing of the mental capacity in children. There's going to be headaches, especially in the morning. There's going to be neck pain. There's going to be vomiting. There's going to be blurred vision, double vision, stunted growth. Sorry, there's a problem with that spelling. Precocious puberty, spasticity, and
next slide.
Leading to.
I'm sorry, I have an audio. Did you say next slide?
Yes, next slide.
Okay, there we go. I'm just having trouble hearing you sometimes.
All right, and I just want to apologize to
No, we appreciate you making the effort. Thank you.
Listen to a presentation. Actually, it's one
no problem.
PowerPoint, and yes, okay, good. There's a message from Ulrich. Okay, so in adults, the symptoms in adults include cognitive deterioration, headaches, neck pain, There's nausea, vomiting, blurred vision, double vision, difficulty in walking, drowsiness, and incontinence. Next slide, please. So the physical findings in infants include head enlargement, as we already explained, disjunction of sutures, dilated scalp veins, tense fontanelles, setting sun sign, increased limb tone, papilledema, failure of upward gaze, Maureen sign, which is a crackpot sound noted on the percussion of the head in children, and the unilateral or bilateral seat cranial nerve palsy. Next slide, Dr. So the physical findings in adults include, as we already said, a papilledema, failure of upward gaze, and the accommodation indicating pressure on the tactile plate. There's also unsteady gait. There is large head if it is since childhood. That is, if the hydrocephalus is present since childhood, there's going to be enlargement in the head of children, and there's going to be the physical presentation in normal pressure hydrocephalus are increased reflexes. I think that Dr. Kabul is going to better explain this. There is a difficulty walking, and there's the presence of primitive reflexes. Next slide, please. So to make a diagnosis of hydrocephalus, you first of all have to do a good anamnesis. So after an anamnesis and physical examination, some workup might be requested to confirm the diagnosis and rule out differential, as well as evaluate the extent of damage. So the laboratory investigation you will need to do are genetic testing in case of suspecting X-linked hydrocephalus, as we explained earlier, CSF fluid evaluation in post-hemorrhagic and post-meningitis hydrocephalus, screening of the mother in case of a congenital hydrocephalus, if to see for example, the germ that could have caused the hydrocephalus. Next slide, Dr. John. Next slide.
Is that diagnosis?
Yes, next slide, doctor.
Yeah, it's not okay. It's not going forward. There we go.
Okay, so we have already spoken about the laboratory investigation that we can do for that. Now let us now see the imaging studies you can do. So you should do a CT scan, that is to see the size of the ventricles. You should do an MRI. You should do, and the criteria that will help you to define if it is a hydrocephalus or not on the CT scan or the MRI are the sizes. The size of both temporal horn. That is, it should be greater than 2 millimeters. And you should note that the temporal horns are not clearly seen in absence of hydrocephalus. So the ratio of the other criteria that we should use is the ratio of largest width of frontal horns to maximal biparietal diameter. And if it is greater than 30%, you have a case of hydrocephalus. We also use a transependymal exudate in translated on. Transependymal exudate is translated on images as a proventriculus hypoattenuation or superintending on the based on if seen on the CT and the MRI. And also there's going to be ballooning of the frontal horns of lateral and third ventricle, that is called the Mickey Mouse ventricle, Mickey Mouse sign, and it is indicating aqueduct obstruction. You can also have upward bowing of the corpus callosum. So if you have all these five indications, then it is most relative of the hydrocephalus. Next slide, Dr. John. And now to determine if it is a chronic hydrocephalus, you are going to have a temporal horns that may be less prominent than acute hydrocephalus. Also have third ventricle. Third ventricle may terminate. May herniate into a cellar tussica. The cellar tussica may be eroded. It might also have a macropenia, and you have a corpus. The corpus callosum may be atrophied. That is in ex vacuo. As I said, there's a type of hydrocephalus where there's some sort of atrophy, and the CSF fills the space that is being left, and so it's not really a hydrocephalus, but some consider it as being a form of hydrocephalus. Next slide, Dr. John. So on ultrasound, through anterior fontanelle here you do through anterior fontanelle to evaluate the subependymal and the intraventricular hemorrhages and possible development of progressive hydrocephalus. We also do radionuclide cysteinography. You can also do a skull radiography, and you can also use an EEG and a lumbar puncture. Next slide, Dr. John. So now that you have already seen the different presentation and how to make a diagnosis of hydrocephalus, let us now have an idea about the management of the hydrocephalus. So we can have different groups of management. You can have a medical care, and here this care compared to the surgical care is just used to delay the surgical care. So this is not the best management, but sometimes we can use it. We can give the patient some medical care. So as we said, it is used to delay the surgical care, which is the most and the mainstay of management of hydrocephalus. And normal CSF physiology may resume during this period of care, thus avoiding surgical intervention. So you can have a patient having, the hydrocephalus will resolve and everything will go back to normal when giving the medical care to the patient. But it is not effective for long-term management of chronic hydrocephalus, and it may include metabolic side effects, and those should only be used temporarily. The drugs used here work with different mechanisms to alleviate the hydrocephalus. Next slide, Dr. John. So in the medical care, the drugs that you give to the patient work by different mechanisms to regulate the CSF dynamics as follows. So there's either going to be decreased CSF secretion by the choroid plexus, and the drugs that do that are responsible for this, we have acetazolamide and the furosemide. And you can also increase CSF reabsorption, and the one mainly used here is isosorbide, though there's some sort of worry concerning this. Okay, so acetazolamide can be used alone or in synergy with the furosemide, and it's mainly used in post-hemorrhagic hydrocephalus in neonates. So it is a non-competitive reversal inhibitor of carbonic anhydrase, which leads to decreased CSF secretion by the choroid plexus. Furosemide lowers the sodium uptake, affecting water transport into the cells by inhibiting cellular membrane cation chloride pump, as well as inhibiting the carbonic anhydrase enzyme. Next slide, doctor. So, having seen on the medical care, which I repeat is not the appropriate care for hydrocephalus, it's just a measure to delay. It's just a measure that we can use if there's a problem for the patient to have access to surgical care. The main treatment for hydrocephalus, depending on the type, also is surgical care. So what is present in the surgical care? This is, as I say, is a preferred therapeutic option over medical care, and it includes, you can do a lumbar puncture, you can do a choroid plexus cauterization, you can do shunting. We have opening of stenosis. Enlarge the stenosis. We have removal of tumor compressing the ventricular system, as I explained earlier. If you can also have due to an external obstruction. We also have endoscopic fenestration of the third ventricle as a surgical measure. We have ventricular tap. We have open ventricular drainage, and each technique has advantages and disadvantages. Just a balance of two should a balance of the two, the advantages and the disadvantages, should be made before using the any of the techniques. Next slide, Dr. John. So let us see a lumbar puncture. So it is useful only in cases of communicating hydrocephalus. So you should first of all make sure that the patient has a communicating hydrocephalus before you use the lumbar puncture as a measure to relieve the patient from the hydrocephalus. And it's often done in post intraventricular hemorrhage hydrocephalus. In the case of choroid plexus cauterization, this may be used in cases of excessive production of CSF or CSF. Here, what you do is that, as the name indicates, choroid plexus cauterization, we coagulate the choroid plexus. thus reducing the production of CSF by these current plexus. So we have shunting, which is performed in most cases of hydrocephalus, and it is up to 75% of hydrocephalus patients are treated using this method worldwide. And it involves the placement of ventricular catheter into the cerebral ventricles to bypass the flow obstruction or the malformation and drain the excess fluid into other body cavities where it can be reabsorbed. Next slide, Dr. John. So the different shunts, the shunts drain the fluid into, so as we said, it can either drain it into the peritoneal cavity. In this case, it is called a ventriculoperitoneal shunt. You can drain it into the right atrium. It is called a ventricular shunt. You can drain into the pleural cavity where it is being called a ventriculopleural shunt, and into the gallbladder, and also in the lumbar peritoneal. You also have lumbar peritoneal shunt by connecting the lumbar region to the peritoneum. So some complications and those drawbacks in using shunts include headaches. The patient can have headache. We have vision problems, irritability, fatigue, personality change, loss of coordination, difficulty in walking, um, uh, a return of working difficulties. For example, if the patient had difficulty walking before, as you say, which is a sign of hydrocephalus, when treating the patient, you can have a return of all this, which is a complication of the shunt, because if maybe there's an obstruction of the shunt, it's no more going to be doing its job, so leading back to a build up of CSF in the ventricular system, and thus continuously giving the presentation the patient came with. You also have mild dementia or incontinence. In infants, the symptoms of shunt malfunction can include all of the above, as well as vomiting and inappropriate head group, and of course the sunsetting eyes. So fortunately, most complications can be dealt with successfully. So if you realize there's a case of obstruction, you just have to either remove it and redo it all over. And if, for example, there's a problem with excessive drainage of CSF, you just have to regulate the amount of CSF that you are draining. So most of the complication of shunts can be managed eventually if we exclude some kind of infection, though we can also manage the infection. Next slide, Dr. John. So the other method of treating hydrocephalus is endoscopic third ventriculostomy, or ETV, or it can also be called endoscopic fenestration of the third ventricle. And an opening in the, and it is being done how there's an opening in the floor of the third ventricle, which is made and allows the CSF to flow directly to the basal systems, thereby shortcutting any obstruction in the aqueductal stenosis. For infants, this technique is sometimes combined with correct plexus cauterization, and I already explained the correct plexus cauterization the previous slide. Next slide, Dr. John. So let us now have a word about the prognosis of hydrocephalus. The prognosis depends on the cause of the hydrocephalus, the extent of the symptoms, and the timeliness of the diagnosis and the treatment. So it's very important to act earlier if you would like to have a better prognosis. Some patients show a dramatic improvement with treatment, while others do not. In some instances of normal pressure hydrocephalus, dementia can be reversed by shunt placement. Other symptoms, such as headache, may disappear almost immediately if the symptoms are related to the elevated intracranial pressure. In general, the earlier hydrocephalus is diagnosed, the better the chance for successful treatment. Of course, if you allow the hydrocephalus to stay for long, there can be some irreversible brain damage. So the earlier you manage the patient, the better for the patient. The longer the symptoms have been present, the less likely it is for the treatment to be successful. Unfortunately, there is no way to accurately predict how successful surgery will be for each individual. And some patients will improve dramatically, while others will reach a plateau or decline after a few months. Next slide, Dr. John. So shunt malfunction or failure may occur also, and the valve can and the valve can become clogged, or the pressure in the shunt may not match the needs of the patient, requiring additional surgery. In the event of an infection, antibiotic therapy may be needed, and likely, unlikely temporary removal of the shunt and replacement by a drain until the infection is cleared. The shunt can be reimplanted when, and when there's a shunt malfunction, a surgery is often needed to replace the blocked or malfunctioning portion of the shunt system, as we already explained. So next slide, Dr. John. Neurological function should be evaluated post-surgery. If any neurological problem persists, rehabilitation may be required for further improvement. However, recovery may be limited by the extent of the damage already caused by the hydrocephalus and the brain's ability to heal, the plasticity of the brain. So because some causes of hydrocephalus are ongoing conditions, long-term follow-up is required, and the follow-up diagnosis takes include a CT scan, MRI, X-ray, and all of these are helpful in determining if the shunt is working properly beside the physical examination. So if you have physical examination, evaluate your patient. If your patient is not improving, then you can now to be sure that it's maybe due to any malfunctioning. You can request any of the tests to confirm your doubt. Next slide, Dr. John. So in summary, hydrocephalus is a frequent condition and carries a high morbidity rate. Some causes of hydrocephalus has some sex and age predominance. Hydrocephalus has various mechanisms responsible for its onset. Thus, treatment knowing the underlying cause helps to orientate on which modalities to use, and which will eventually help improve the outcome of the patient. Surgical care remains the mostly used treatment modality and the best, and the prognosis will depend on the cause, the extent of the symptoms, and the timeliness of diagnosis and treatment. Studies need to be done to fine-tune knowledge on hydrocephalus and care delivery to the patient with hydrocephalus. Next slide, Dr. John. These are my references, and next slide. Thank you very much for your attention. So here we have health is a human right that 400 million are waiting for. So we should act for this. We should put in place measures that permit these 400 million people to have access to their human right, which is health. Thank you very much.
Thank you, Zolo, for another great presentation. That's a lot of work to put that together. And we'll open the panel for comments or questions. Any comments, Marco?
First of all, let me allow to tell Zulu is a great presentation, very complete, very exhaustive, because he got all the aspects of the hydrocephalus, from the newborn hydrocephalus congenital to the adult hydrocephalus. It's not so easy to do, but it's a great job. Congratulations, Zulu. I want to just highlight about the complication of ventricular shunt, and I liked in case where there is an infection of ventricular shunt, and you have the diagnosis doing a tap on the valve, don't attempt any conservative way. Just remove the shunt and put an extra ventricular drainage, because in this case time is precious.
You know, I also have a comment, Marco. Someone wrote in from Nigeria, a Nigerian neurosurgeon whose name is Adikola Olomo. He's a neurosurgical resident. He asked, what antibiotics do you use to prepare the shunt hardware to avoid problems like you're talking about, infection?
Well, first of all, I do prophylaxis antibiotic 2 hours before the surgery. I use cephalosporin, use cefazolin 2 gram. And I attempt to do surgery as a first case of the morning, because of course you clean the operating room after every operation, but it is obvious that the operating room is cleaner at the first case than at the last case. Of course.
That's a good point. That's a good point.
And another things, prepare the skin. So shave the skin of patients where you need to operate using alcohol solution. I use the scrubs, the same scrubs I used to clean my hands before surgery. And use a frequent shift of your blowers. So if you start to cut the skin, then after you expose the bone, change the glowers, because of course the skin is cleaned, but is the part that can be more contaminated by bacteria. So cut the skin, then after you expose, change the glowers. You, your helper, and your nurse in the operating room. That's my my way to do a ventricular shunt.
Okay, thank you.
Hello, thank you, Dr. Meloni. Thank you so much. About the question, if I can add to what Dr. Meloni said, I'll just send in a message right now, the link to an article that everyone can read, especially those from low and middle-income countries. This was published really recently by Professor Kalangu, who is a former vice president of WFNS and works in Zimbabwe, with other neurosurgeons in 3 different countries. They did a multi-centric study on shunts.
Can you share the screen with that?
Yeah, let me get you.
Okay.
So let me get the original one, and I'll share the screen. So they did this study, and they've explained step by step how you can get to zero shunt in a low resource setting. It's a very interesting study, especially because we know that, well, ETVs are good, they're cool, but at the moment, not everyone can get ETVs. So we are left with our good old Shabras. Let me try and unlock this so everyone can see. They have everything with, Dr. Meloni explained it very well, about how you need to prepare the skin, how you need to shave. They have everything, how you need to get your cases in first in the morning. You need to limit your cases. That's why it's not a good idea to have these campaigns during which you go to an area and then you're operating 30 kids because it's a hydrocephalus campaign. That's not a good idea. You'll get a lot of infections. So as you can see here, protocol to minimize infection. The title of the article is Towards Zero Infection. I sent the link in the message. As you can see, shunts done in the morning, neonates and infants before older patients. It's a long list. It's a really long list, and they have their results. A very interesting thing about this study is in their results, they actually found out that the primary cause of hydrocephalus was not post-meningitis hydrocephalus, was actually third ventricle aqueductal stenosis. So that was a change, because we usually thought that in a context it was due to infection. So I invite everyone to read this. Thank you very much.
Thank you. Okay, any more comments or questions from Ahmed? I don't think we met you, Ahmed. Do you want to introduce yourself? Are you there, Ahmed? Possibly not. Any comments, Dewin, from another student, former presenter later?
Well, I think it was a great presentation. Can you get me?
Yes, we get you.
Yes, it was a great presentation, though I came in late, but yeah, I think that's what I can say. It was a wonderful presentation.
Okay, thank you, Dewin. Okay, very good, everyone, gentlemen, because Nathalie's not here, but I'll speak to her about that. Thanks everybody for coming, and we'll end this presentation formally, and we'll start the next one with the gym. Okay, we'll stop here. Thank you. Okay, so we stopped that, and now we're going to start another one. Now, DeWin, you're presenting now, correct?
Yes, yes.
Okay, I can't see your screen there. Are you okay with that? Because I got your presentation. You want to try to present, or you want me to present it? What do you want to do?
Okay, let me try.
Okay, yeah, let's try. If you have a problem, just say, Dr. Bennett, take over, and I got your presentation, okay?
Okay, sure. Let me
Okay,
just try.
okay, let me see your face first, because I'm going to introduce you.
Okay.
There you go. Okay.
Let
me introduce you. So. Let me introduce you formally first, and then you can go into your screen sharing. Okay.
Yeah, sure.
Okay. Direct hemorrhages, correct?
Yes.
Okay. Here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon. This is Dr. John Bennett broadcasting from Miami Beach, the studios of Neurosurgical TV. I don't know why the camera's not going to me, but anyways, we have the pleasure of having DeWin. He's a medical student from the Cameroon. He's going to give a presentation on direct hemorrhages.
From Zimbabwe. He's from Zimbabwe.
Oh, I'm sorry. Zimbabwe.
Zambia.
Oh, Zambia.
Zambia.
Oh, my goodness.
We're both wrong. Okay, well, welcome. Welcome, and let's introduce the other panelists first before we turn over to DeWin. Hello, Zolo.
Hello, Dr. John. Hello, everybody. Sorry, there is a problem with light here in Neo. So the light supply company has a problem. So I'm Zolo Ivan, a medical student from Cameroon. I'm happy to be here. I'm a member of the Association of Future African Neurosurgeons. It's a pleasure being with you.
Thank you, Zolo. You just gave a great presentation on acute hydrocephalus. Welcome, Ulrich.
Hello, everyone. I'm Ulrich Sidney. I'm research associate at the program of Global Surgery and Social Change at Harvard. I'm the founder of this group, the Association of Future African Neurosurgeons. Nice to meet you all.
Okay, and Ulrich put together these free presentations. I appreciate that. Hello, Kelvin. How you doing? Could you please introduce yourself? And
yes, thank you, Dr. Ben. Thank you, Dr. Bennett. I'm Dr. Kelvin Nemaire from Zimbabwe. Consultant neurosurgeon, currently neurosurgical fellow in Scout-based, based in Turkey. It's a pleasure to be here.
Welcome. We appreciate your any participation in the future. Okay, DeWin, welcome, and it's all yours.
Thank you so much. I'm glad to be here. So I'll be presenting on direct hemorrhages. Let me just share my slide.
Okay.
Okay.
There you go. You want to make it a little bigger?
Okay.
You may have to maximize the screen.
Well, I'm using my phone, so
I'll try. Okay. Oh, well, okay. I'm sorry. I didn't realize that. Okay, that's fine. That's fine. That's fine.
Sorry.
Beautiful.
Okay. So I'll be presenting on like I was introduced. I'm Darwin Chimba from Zambia. I'm a medical student at the Copperbelt University, just within Zambia, and I'm a member of the Association of Future African Neurosurgeons. So I'll be presenting on direct hemorrhages. So on introduction, the definition of direct hemorrhages, these are just small areas of bleeding in the ventral and paramedian parts of the upper brainstem, or rather the mesencephalic and pons. So they were first described in 1878 by a French surgeon, Henry Girard, who lived between 1849 and 1921. So this is where the name of the pathology came, that is direct hemorrhages. And they're also called pontine hematomas. So as you can see from the diagram there, this is just a sketch. We have the part where the arrow is pointing there. That's why we have there are those linear small lesions that are on the pons on the brainstem. So those are the direct hemorrhages. So some of the risk factors that are associated with direct hemorrhages, these are not all though. So based on these are just basically based on clinical observations, and they're as follows. So one, we have arterial hypertension as well as advanced age. So according to some clinical observations that have been done in different settings, it has been found that those patients who are having arterial hypertension and are advanced in age, they are more likely to suffer from these direct hemorrhages. So the causes of direct hemorrhages, some of the causes include traumatic brain injury, where there is a cranial cerebral trauma with rapid evolving descending transtentorial herniation. So direct hemorrhages secondary to transtentorial herniation account for about 4.6% of all intraparenchymal hemorrhages. So when you look at all the intraparenchymal hemorrhages that are there, these direct hemorrhages, they account only for about 4%. So they are quite a rare condition, but as we shall discuss later, we'll find that these are quite fatal. So other than traumatic brain injury, other space occupying lesions such as tumors, they can also cause these direct hemorrhages. So basically here we're just looking at a situation where the supratentorial pressure is increased. So anything that will increase the supratentorial pressure and eventually lead to herniation it will potentially cause these direct hemorrhages. So as we know about the Monro-Kelly hypothesis, where we say the cranium is a fixed space composed of the brain tissue, blood, and CSF. So if any of these increases, then it is going to lead to a decrease, a compensatory decrease in the other two. But if that there's no compensation, then what we're going to find is that there's going to be herniation. So whatever is going to cause that intracranial pressure to increase and eventually increase the chances of herniation will also increase the chances of having these direct hemorrhages. So also other bleeding disorders where there's going to be bleeding, intracranial bleeding, which is almost the same as what is happening in traumatic brain injury, where, for example, you can have epidural hematoma or subdural hematoma. So any other bleeding disorder which will cause bleeding within the skull will also predispose a patient to having these direct hemorrhages. So what we're saying is that these ultimately lead to increased intracranial pressure and eventually herniation, and then there's going to be development of those direct hemorrhages. So the pathophysiology of direct hemorrhages is basically not so certain, but it is believed that they are due to shearing, or rather tearing and stretching of the perforating branches from the basilar artery to the pons. So when that herniation is taking place, what we'll find is that there's going to be shearing, or rather there's going to be stretch and tearing of the perforating branches of the basilar artery, which supplies the pons and part of the midbrain. So because of that, there's going to be development of these it follows increase in supratentorial pressure, like I mentioned, that whatever will increase the supratentorial pressure will cause development of descending transtentorial herniation. Then other than the arterial origin of these direct hemorrhages, where we're saying that there's going to be tearing of these the perforating branches of the basilar artery. We can also have a venous origin of these direct hemorrhages, where we're going to have venous thrombosis and infarction. So these are also implicated. Venous thrombosis and infarction is also implicated and may play a role in the development of these direct hemorrhages. So these combined are going to result in parenchymal hemorrhage. Okay, so the hallmark of direct hemorrhages is that it is accompanied with a large supratentorial pathology causing severe mass effect. So whenever there's a mass effect, which will probably lead to herniation, it will lead one to either lead to tearing of the perforating branches of the basilar artery, which is supplying the part of the midbrain and the pons, or there can be venous thrombosis and infarction. So these two combined, or one of them, is going to lead to development of these basilar hemorrhages. So as we shall discuss later as well, we'll find that if there's no accompaniment with this large supratentorial pathology, then we cannot call it to be direct hemorrhages. Instead, we're going to have other possibilities which we're going to discuss. So the diagnosis of direct hemorrhages is basically done by imaging, that is either by CT scan or MRI. So the classical appearance of a direct hemorrhage is one located in the midline near the pontocephalic junction. So they may also be multiple, even to extend into the cerebellar peduncles. So it's not just the midbrain that may be affected or the pons that may be affected, but in a case where they are multiple, then they can also extend into the cerebellar peduncles. So this is just an extract of a CT scan showing some hypodense areas which were defining as the direct hemorrhages. So as we can see from the red arrows that are pointing on the images there, so that's why we're having the direct hemorrhages. We can see that there are some hypodense areas there. So like I mentioned, we said that the hallmark of direct hemorrhages is when it is accompanied with supratentorial pathology, where there's going to be a mass effect, and then there's going to be a herniation and so on. Now, in the absence of those, in the absence of large supratentorial pathology causing severe mass effect, other diagnoses that we should also think of, other than just these direct hemorrhages, we can think of primary hypertensive hemorrhage within the pons. So these are usually larger compared to the usual direct hemorrhages. So if we're to compare these hemorrhages that are occurring due to primary hypertension and the hemorrhages that are occurring due to herniation, which we are calling the direct hemorrhages, we're going to see that the primary hypertensive hemorrhages are going to be slightly larger than the actual direct hemorrhages. Other than that, we can also have axonal brain injury affecting the pons. So usually they are multifocal and are usually smaller. So if we're to arrange them in size of in order of size, so you have the primary hypertensive hemorrhage being the largest, then the direct hemorrhages being second, then axonal brain injury, which is affecting the pons, is going to be least in terms of size. And the axonal brain injury affecting the pons are usually multifocal. So the treatment is not well known, but it involves the usual way or other method of treating pathology such as traumatic brain injury, because here we're trying to reverse the hypoxia and further bleeding. Okay, so on the part of prognosis, the direct hemorrhages are frequently associated with mortality, and they are a marker of poor prognosis. So most of the times what we find is that in a patient with, for example, traumatic brain injury, if they do not have durate hemorrhages, if there's no development of
Peter, you learn to share.
sorry.
I'm sorry. Continue on. Continue on.
Can you mute
So,
Kiproko, please? Dr. Bennett, can you mute Kiproko?
I can hear. Who do I need to hear?
Can you mute Kiprop?
Okay. Okay. Yeah, I will. Okay. Go ahead. Continue.
Okay. Thank you.
Yeah.
So I was on treatment and prognosis. So I was saying that there's no proper documented way of treating these durate hemorrhages. But one of the things that should be involved is a thorough way of treating pathology such as traumatic brain injury, where we basically try to reverse the hypoxia and further bleeding within the skull. So these durate hemorrhages, they are said to be frequently associated with mortality, and they are a marker of poor prognosis. So if we're to compare, if we have two patients, two patients with traumatic brain injury, one has these durate hemorrhages, the other one does not have durate hemorrhages. The one without durate hemorrhages is likely to recover better and quicker than the one without, than the one with these durate hemorrhages. So prognosis in those patients with durate hemorrhages is quite poor. So this has been historical, like in the past, it has been like reported that outcomes in patients with these durate hemorrhages. So as we shall see, there are two cases. I've tried to include two cases where one recovered, the other one did not recover well. So case one, so this was an extract from one of the articles that I came across. This is a case of a male 76 patient who presented to the emergency department with unconsciousness and fixed dilated pupils. So according to the family, the patient was drowsy and difficult to arouse, which prompted them to call the emergency medical services, or rather EMS. At the time EMS arrived, he was able to maintain his air. So en route to the emergency department, the patient was intubated and mechanically ventilated. So obviously this was to try to reverse the hypoxia and whatever secondary brain injury that could occur. So his pupils were fixed. On the past medical history of this patient, he had coronary artery disease. He had CABG, that is 3 times, and then he also had atrial fibrillation, peripheral vascular disease, then recent Staphylococcus aureus sepsis, for which he was treated with antibiotics. So among his list of medications, he was being treated with dual hypertensives, antihypertensives, as well as dalteparin. So the available documented BP measurements were normal to low during his various hospital stay. So upon arrival and following relative stabilization, a CT scan of the head was expediently arranged. So those are the images of the CT scan showing the hemorrhage just on the left side of the brain, and there's also a midline shift. So let me just read the report. So the head CT reading, the scan demonstrated a large left frontal parenchymal hemorrhage with a hematocrit effect. There is significant mass effect, including one, there was a 2 centimeters midline shift. Then there was left ankle herniation. Then there was also descending transtentorial herniation. Then there was cervical effacement of the left lateral ventricle that is slit like, with ballooning of the contralateral temporal horn. So there was also low-lying cerebellar tonsils with fullness of the posterior fossa. So as shown in the images that I showed. So the other finding in the CT scan was parenchymal hemorrhage. So there were areas of subarachnoid hemorrhage and extension into the ventricular system. So if we can look at the arrows there, the blue arrows, they are showing that there's subarachnoid hemorrhage, and there's also extension into the ventricular system. Then there was also pontine hematoma. Okay, so now this pontine hematoma is what was called the Jurette hemorrhage. So there were while there were other pathologies, okay, like we have mentioned, one of the things that will lead to the development of these Jurette hemorrhages is transtentorial herniation, descending transtentorial herniation. Okay, so since there was development of this transtentorial herniation, then the patient was prone to development of the Jurette hemorrhages, which were a classical finding in this particular case. So as we can see from the images there, we can see that part of the brainstem there, it can show some hypodense areas, which are the pontine hematoma, or rather what we're calling the Jurette hemorrhage. So in this particular patient, unfortunately, okay, this patient even died or rather passed away soon after the scan was done. So you can see that in this particular patient, it was very hard, or rather this patient had a poor prognosis, because before it could even be managed efficiently, the patient passed away. So that's why we're saying that historically, these Jurette hemorrhages have been associated with poor prognosis and severe morbidity. So let's look at case 2. So case 2, this is also an extract from Shunsuke. So it is a case of a patient who presented with Jurette hemorrhage caused by an idiopathic, the two idiopathic words there. So caused by idiopathic subdural hematoma, who demonstrated dramatic recovery. So as compared, or rather as contrary to the previous case, where the patient died soon after the CT scan was done, this particular patient actually demonstrated a dramatic recovery, which was quite shocking, and it was probably different from what was being experienced from the other cases. So the patient presented with a low GCS score and bilateral oculomotor palsy on admission. So preoperative CT revealed a large subdural hematoma and Jurette hemorrhage of the midbrain. So the subdural hematoma was immediately evacuated under local anesthesia, and the patient demonstrated dramatic post-operative recovery with no residual quadriparesis and minimal cognitive dysfunction. So bilateral oculomotor palsy otherwise persisted. Okay, but the other findings that were there, they resolved, except for the bilateral oculomotor palsy, which we were saying that it persisted in this particular patient. So this indicates that Jurette hemorrhage restricted to the central portion of the midbrain without severe primary brain injury has a good prognosis. So in a case where even if a patient has a Jurette hemorrhage, so there are chances that this patient can have a good prognosis, especially if these Jurette hemorrhages are restricted to the central portion of the midbrain without severe primary brain injury. So as compared to the other patient, the other patient, the Jurette hemorrhages were quite extensive, but this patient, it was basically restricted to the central portion of the midbrain. So depending on the severity of these of these direct hemorrhages, or how much of the midbrain they are actually involving, then we can have a good prognosis in most in patients. So what are we saying in conclusion? So direct hemorrhages have historically conferred devastating prognosis. They are frequently been associated with death, prolonged disorders of consciousness, or devastating functional disability, including quadriparesis. However, recent studies have shown that direct hemorrhages are not always associated with poor prognosis, especially those caused by simple subdural hematoma. So I had to include these two cases so that we try to compare the prognosis, rather the outcomes of patients that are presenting with direct hemorrhages. So historically, like I mentioned, they have been known, or rather they have been, it has been known that they carry a poor prognosis. But recent studies and recent cases that have been handled are showing that actually patients with direct hemorrhages can also have a good prognosis, especially in a case where they are caused by simple subdural hematoma. So those are my references. Thank you very much.
Okay, Dewen, thank you for a great presentation, and thank you for the preparation. And let me just get you off the screen share there. Can you get off the screen share, Dewen?
Sir?
Yeah, let me just take you off the screen share, okay?
Sure.
Yeah, just so we can see your face. Okay, stop share. You know, one thing we have to realize when we watch a presentation by Zolo and Dewen, they are doing those presentations from a smartphone. The two quality presentations. So anyways, let's introduce a new panelist before we turn it over to Dewen to answer questions. Abdullah, can you please introduce yourself, please? Can you hear me okay, Abdullah?
I hear you.
Yeah, please introduce yourself.
My name is Dr. Abdullahi Jimo. I'm a neurosurgeon in Nigeria. I'm currently in Rabat, Morocco for some fellowship, and I'm just introduced to the program by Dr. Bankole Nuruddin.
Very good. I notice he's here too. And welcome, Abdullah. You can come to any presentation of ours.
Dr. Jimo, hello.
Yeah, hello.
Hey.
How are you, Ulrich?
Yeah, I'm good. I'm good. How you doing?
Good to see
it's been
you.
A while.
Very a while. I hope I'm not wearing anything.
Does your camera work? Does your camera work? We'll put your camera on so we can see your face, so we can, Naru and Ulrich can see you.
Okay, let me put on some dress.
Yeah, in the meanwhile, we'll meet Dr. Naru. Hello, Dr. Naru.
Hello, John. Nice to meet you. Miss you all, guys. It is so long time.
Hey, welcome, Naru. And Dr. Kabulo, could you please say hi?
Hello. Hello, everyone. My name is Kabulo from Democratic Republic of Congo, currently final year neurosurgery resident at the University of Zimbabwe.
Okay, he's going to present next.
I hope I will see you, Kabulo, in Kinshasa in November. I'm coming.
Okay, Cyril, are you there now? Can you please introduce yourself? Cyril, can you hear me okay? Perhaps.
Yeah, hello.
Perhaps not. Cyril, can you hear me? Oh, Abdullah, your camera is working. I can see it. There you go. There you go. You can see Naru and Ulrich. I think Ulrich may have stepped away. Okay.
No, I'm here. I'm here.
There you are. Okay. There we go. Okay. Let's open it up for panelists' comments and questions. Oh, we didn't meet Cyprop. Cyprop, can you please introduce yourself? Go ahead. I muted you. Go ahead. Go ahead, Cyprop. Go ahead. Please introduce yourself.
Hello.
Hello, we can hear you.
Hello, yeah, this is Dr. Kiprop Ngetich from Kenya, University of Nairobi, neurosurgery resident.
Excellent, excellent. Another African country represented. Excellent. Morocco.
Nice to meet you, Kiprop. I hope we will meet together for next scans in Nairobi with Professor Koreshi.
Sure. I hope we will. This is my first time in this. I hope with time I'll be able to catch up with you guys. Thank you.
Oh, great.
Welcome.
Great.
Okay.
Nice to meet you.
Okay, we can open it up for comments or questions from the panelists. Any comments or questions?
Today we have great presentation about, I don't know this guy before, but I appreciate a lot of his presentation about dural hemorrhage. It is one topic that I really love, and I fix sometimes involved with this dural hemorrhage in my shift, in my little experience, and I love the way that he treats the topic. And after, when you take in literature to show them some little review about that. So congratulations, Dr. Please, can you, Dr. Dawin Sishimba?
Dawin, right.
Great and well done. I appreciate that. I appreciate your
Thank you very much. Thank you so much.
And,
yeah, he just stepped away.
Looks like you do good review, so I don't have any comment, because all that I want you have to say, you say that in your presentation. So I just want to congratulate you, and good job.
Thanks, Naru. We didn't meet Dylan. Dylan, welcome. Go ahead, Dylan, say hello. Please introduce yourself. Go ahead, Dylan, you can hear me, right?
Hello?
Yeah, go ahead, please introduce yourself.
Yeah, hello everyone, is Dr. Dylan Jofak. I'm general practitioner from Cameroon. Nice to meet you all. I'm in a taxi right now, so I can't really put on my video.
Okay, well, thanks for coming. Thanks for coming. Any comments or questions, Dr. Kabulo, on direct hemorrhages for Dawin?
Thank you so much, Dawin. That was a great presentation. So let's recognize that he did well. This is his first presentation on this panel, in this platform, and he did very well. So
thank you, Dr. Kabulo.
You're welcome. The only comment I will make is just to, next time you go and check the phases of the degree of herniation, okay, then at which level you start to get the dural hemorrhage. Yeah.
Okay. Okay. Thank you so much, Doctor.
Okay. Very good.
Yes, I am agree with you, Kabulo. You are right.
Okay. Yes. Dr. Kelvin want to say something?
Okay, Kelvin, go ahead. Go ahead, Kelvin. I'll unmute you. Go ahead, Kelvin.
He's my senior.
Yes, thank you very much, my colleague from Zambia, for the excellent presentation. And
thank you
obviously,
very much.
Yes, greetings to all the colleagues across the world. What I wanted to say was, if things have changed, I'm not very sure, but I thought dural hemorrhages were usually considered a histopathological diagnosis. And since these are petechial bleeds, you cannot really see them on a scan. I'm not really sure if there's recent literature which says anything to the contrary. Thank you.
Okay, any comments on that? Go ahead.
Maybe I can try to say something.
Okay, go ahead.
Sure.
Yes. So part of the literature that I came across, it said that these are usually autopsy findings. So they're usually it's a diagnosis that is made on autopsy. But
Sure.
also some other literature that I came across as well, as we can see from those CT scan images that I showed. Usually they present on CT scan. They present with hypodensity. So I think according to the literature that I came across, I think it's both on autopsy as well as on CT scan. Though obviously I stand to be corrected.
Yeah, no, it's okay. Thank you so much.
So
You're
there's
welcome.
thanks, Darwin. I just wanted to show Dr. Kelvin. There's this page on Radiopedia where they have the presentations of direct hemorrhages and different cases like radiographic cases. So I can send the link in the group.
Yeah,
Thanks,
sure,
my brother.
sure.
Yeah.
Thank you.
Okay, good, good. I want to add something. Maybe sometime we can find the hypodense area surround the hemorrhage. Sometimes we can see that just about the when the hemorrhage start to resorption, we can have surround the area hypodense, and sometimes when you have ischemia about the midbrain, you can have also hypodense, but always we know that when you have hemorrhage, it is hyperdense. So sometimes you can get nuance, so it is okay. It is okay, and good job, Darwin. Good job.
Thank you very much.
Yeah.
Okay, very good. Any more comments or questions before we close this and move on to Dr. Kabulov's talk? Okay, thanks all panelists for coming, and you're welcome to come to any of the presentations.
I think Dr. Abdullah want to talk. Please unmute your microphone. Unmute.
Okay, yes, I have unmuted it. It's a great honor to be among the panelists. This is my first time of joining the panel. In fact, Dr. Nuruddin is in the other room. He just told me and attempt to register to the Zoom application. I just got the last 3 slides, and I'm happy to be part of it. I didn't get the whole essence of the discussion, but based on the comments by others, obviously it's a good report, and I'll be glad to be part of it in the future.
Okay, do I have your email?
You are welcome.
I need your email address so I can put you on the email list for all the presentations.
Okay, how do I send that to you?
Okay, you just put it in the chat box. There's a chat box. You see the chat at the bottom of your screen.
Yeah, yes.
Okay, open that up
Right.
and just put your
Yes.
email in there, and I'll be able to put you on the list so that you hear about every presentation. And with any presentation in neurosurgery, no matter what continent, you're welcome to join. If you find an interest, say in subdural hematomas going on in Croatia, you can join that still, just as long as you have the link.
It's okay.
So I would like to present Dr. Jimo. It is an associate professor in Nigeria, and it is the same promotion of my old seniors who come here to train in 2005 in Rabat. And now he come back to do fellowship in radiosurgery and stereostatic surgery here in Rabat. So he is with me now, and we would like him to join us and to share with him his experience and his senior experience. So you are welcome, Dr. Jimo, and we are so glad to have you in this panel today. So welcome to everybody, and yeah.
Okay, very good.
Nice to meet you again.
Very good. Okay, let's close this presentation and we'll be on to the next. So thanks everybody for coming. Stay right here. Okay,
we have another presentation.
Yeah, I know. We're gonna edit this out. Let me introduce Dr. Kabulo so we can make each one separate. We're gonna, Doctor, we have a crack team of editors now that slice and dice the presentations. We're gonna make 3 presentations here, separate, so that you have your own video and your growing video resume in neurosurgery. Okay, let's start the next one. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon from Miami Beach. This is Dr. John Bennett, head of Neurosurgical TV. We have another presentation, the third one in a group of 3 for the future African neurosurgeons. And we have today Dr. Kabulo talking about hydrocephalus. He'll tell you about it, what exactly he's going to talk about. Let's meet the distinguished growing list of panelists. Let's start with Kelvin. Could you please introduce yourself?
Yes, good evening. Thank you so much, Dr. Bennett, for having me around. I'm Dr. Kelvin Nemaire, a neurosurgeon from Zimbabwe, currently doing fellowship in Turkey in skull-based neurovascular and neuro-oncology.
Very good. Well,
pleasant evening to everybody.
Very welcome, Kelvin.
Thank
And
you.
Naru, could you please introduce yourself? Go ahead, Naru.
Yes. I am Nuruddin Bankole. I am resident in neurosurgery here in WFN's Rabat Center of Training of Young Neurosurgery in Africa. And nice to meet you all.
Very good. Welcome. Key Prop, could you please introduce yourself? Go ahead, Key Prop. Could you please introduce yourself?
Hello, this is Dr. Kiprop Ngetich from Kenya University of Nairobi, neurosurgery resident.
Very good. Welcome. Okay, Ulrich Sydney.
Hello, everyone. I'm Ulrich Sydney, research associate at the program Global Surgery and Social Change at Harvard Medical School. Equally the founder of the Association of Future African Neurosurgeon. Happy to meet you all.
Very good. Welcome, Ulrich. And Zolo.
Hello, everyone. Hello, I'm Zolo Ivan, a CTM medical student from the University of Buea in Cameroon. I'm a member of the Association of Future African Neurosurgeon, and I'm happy to be here with you. It's a honor. Hello.
And welcome, Zolo. Abdullah Jamo, I'm sorry, I should have introduced you before. Go ahead, Abdullah. Could you please introduce yourself?
Okay, I'm Abdullah Jimo. I'm an associate professor of neurosurgery from Ahmadu Bello University, Zaria in Nigeria, northern Nigeria. Currently, I'm in Hôpital de Spécialité in Rabat, Morocco for fellowship in stereotactic neurosurgery, gamma knife, and functional neurosurgery, and deep brain stimulation for other movement disorders. I'm happy to be here. Thank you.
Okay, very good. You're always welcome to any of these presentations. Dr. Kabulo, no, wait a minute, Dr. Kabulo. Cyril, could you please introduce yourself? We haven't met you yet. Can you hear us, Cyril? Can you hear Cyril?
Yes.
Go ahead, please introduce
I'm
yourself.
Dr. Cyril.
Go ahead.
I'm Dr. Cyril, medical practitioner in Cameroon.
Okay, where are you from, Cyril?
I'm from Cameroon.
Okay, welcome. Very good. And Dylan.
Okay, thanks.
Dylan.
Yes.
Okay, go ahead, Dylan.
Everyone.
Go ahead, Dylan.
Hello,
Go ahead, Dylan.
I'm Dr. General Practitioner from Cameroon and member of the Association of Future African Neurosurgeons. Nice to meet you all.
Okay, welcome, Dylan. Okay, Dr. Kabulo, welcome, and it's all yours.
Yes, Doctor. I don't think we have introduced Darwin.
Oh, I'm sorry, Darwin, I didn't. Yeah, that's right. Thanks, Zolo, for keeping me up to task. Go ahead, Darwin, could you please introduce yourself? Well, he, I think, went out. Okay, Dr. Kabulo, we'll meet Darwin later. Okay, Darwin, excuse me, Dr. Kabulo, welcome, and it's all yours.
Thank you so much, Dr. Bennett. My regards to our seniors on the panel. Dr. Jimo, I met him in Kinshasa last year at the conference in Kinshasa. I was with him there. So nice to meet you again here. And my regard again to Dr. Kelvin, who is my senior. Nice to meet you again. So I'm going to share my presentation. Unfortunately, I lost my final presentation. So I'm just using the draft because my computer restarted at some point and all the editions were lost.
Okay, well, do you want to go back and try to retrieve it, or we can do that if you want. If you want.
Yes, it's okay. No. Can you see now my screen?
Yeah, we can see it. Yeah, it's fine. You can make it bigger. There you go. Perfect.
It's okay. So I'm going to talk about the normal pressure hydrocephalus. Sorry. they are saying low system resources. I don't know. Okay, I will talk about normal pressure hydrocephalus. So no pressure hydrocephalus is a chronic type of community hydrocephalus whereby the increase in intracranial pressure due to accumulation of CSF becomes stable, and the formation of the CSF equilibrate with the absorption. So it's like a syndrome which is characterized by three things. There's gait impairment, cognitive decline, and urinary incontinence. So those three, they are called triad, Akim's triad. So in normal pressure hydrocephalus, you have ventriculomegaly in the absence of elevated cerebrospinal fluid pressure. So like you are seeing on this CT scan and MRI, you can see dilated ventricles, but the brain doesn't look under pressure. You can see the sulci, you can see the interhemispheric fissure, you can see the Sylvian fissure. So dilated ventricles, but with normal pressure. The brain doesn't look under pressure. So the CSF pressure is, like I was saying, in physiologic range, but a slight pressure gradient persists between the ventricles and the brain. So this was first described by Akim and Adams in English clinical literature. This was in 1965. So, and has continued to present many questions with regard to the most reliable diagnosis and prognostic factors, as well as its management. So these are just synonyms of normal pressure hydrocephalus. Others, they prefer to call it low pressure hydrocephalus. Others are saying it's occult hydrocephalus, hydrocephalic dementia, or Akim-Adams syndrome. So in a recent guidelines study, they recommend that normal pressure hydrocephalus can be categorized into two: idiopathic normal pressure hydrocephalus and secondary normal pressure hydrocephalus. Idiopathic means a known cause, but secondary, it can be secondary to subarachnoid hemorrhage, can be secondary to traumatic brain injury, it can be secondary to cerebral infarction, meningitis, and so on. So the frequency of normal pressure hydrocephalus ranges from less than 1% to 6% patient with dementia, and about 45% of such cases are due to idiopathic normal pressure hydrocephalus. So according to pathophysiology, the exact pathogenetic cascade leading to normal pressure hydrocephalus is not known, but there are possibilities which have been put forward. So like intermittent intracranial hypertension, decreased cerebral spinal fluid absorption, and cerebral ischemia. So with distension of ventricles, there occurs distortion of core or central portion of the corona radiata, and the triad of the clinical symptoms can be explained from that. Now, in nuclear medicine, the nuclear medicine revealed impaired blood flow in the edematous white matter. So anatomically, the fibers, the motor fibers, which are going to the legs and the bladder, they are in the periventricular white matter, which is explaining the abnormal gait and the incontinence. So the moment the ventricles are dilating, they are compressing directly those fibers which are going down to the legs and the bladder. And dementia results from distortion of the periventricular limbic system. So in normal pressure hydrocephalus, there are also compression of pedunculopontine nucleus of the brainstem. And that compression could also be responsible for the gait dysfunction, particularly the freezing of gait that has been well described. So intermittent cranial hypertension has been noted in some patients, and the normal pressure hydrocephalus may begin with a transient high pressure hydrocephalus with subsequent ventricular enlargement. So the idiopathic normal pressure hydrocephalus may be a disorder of CSF circulation, probably related to decreased absorption at the arachnoid villi, leading to ventriculomegaly. So whether from an established or unknown cause, the arachnoid granulations fail to maintain their baseline removal of CSF, often secondary to fibrosis or scarring that obscure absorptive interfaces. And you can also get scarring of the subarachnoid space, which has been demonstrated around the base of the brain. However, in many cases, there is no evidence of obstruction of the CSF pathway. So some sources believe that idiopathic normal pressure hydrocephalus is a persistence of poor drainage of CSF originating in childhood as benign external hydrocephalus. There are children with external hydrocephalus where you get more CSF in the subarachnoid hemorrhage comparing to the CSF which is in the ventricular system. So that external persistence, benign external hydrocephalus can also, some sources think like it can be the cause of normal pressure, idiopathic normal pressure hydrocephalus. So they believe that the initial event is diminished CSF absorption at the arachnoid villi. So this obstruction to CSF flow leads to transient high pressure hydrocephalus with subsequent ventricular enlargement. So this new pressure distends the ventricles, stretching surrounding nerve fibers and compressing the periventricular parenchyma. So this encroachment of the brain tissue by enlargement ventricles impinges on the caliber of arterioles and capillaries, often resulting in ischemia. As the ventricles enlarge, CSF returns to normal pressure. So that's a mechanism which is happening there. Now, the pathophysiology of symptoms in idiopathic hydrocephalus is related to dysfunction of periventricular structures. This can be explained by the increased initial tangential stress in this region, the hydrostatic edema, which may occur due to distraction of the ependyma. This is the interstitial edema. You have pressure, high pressure in the ventricles, so the CSF is moving, shifting from the ventricles into the brain, surrounding brain. Then you get that hydrostatic edema or interstitial edema. And later on, the loss of protein and lipids. So in idiopathic normal pressure hydrocephalus, CSF levels of somatostatin and peptide have been shown to be decreased in this patient. And there is also and increased substantially after shunt placement. So the GFAP, gliofibrillary acidic protein, has been reported to be elevated in patients with NPH, and there are changes in CSF vasopressin and brain-specific proteins. So there is an inability to clear potentially toxic molecules and probably other toxic products of brain metabolism, which contribute primarily to the dementia of normal pressure hydrocephalus, as well as secondarily by vasoconstriction, as suggested by some studies. So the chronic or low-grade ischemia with damage to cortical and hippocampal neurons may play an important role in the human syndrome. So the association between idiopathic normal pressure hydrocephalus and hypertension, and subcortical and periventricular white matter abnormalities suggest a possible cerebrovascular role in the development of idiopathic normal pressure hydrocephalus. So the mechanical stretching of the anterior cerebral artery and veins over the corpus callosum and compression of the cerebral micro circulation by the enlarged ventricles would limit the capacity of these vessels to constrict or dilate. So there is what is called the acetazolamide challenge test, which normally increases the cerebral blood flow. It will fail to do so in patients with normal pressure hydrocephalus, particularly in the periventricular white matter. So this lack of the usual vasomotor response to carbonic anhydrase inhibitors or to inhale CO2 probably indicate that the arterioles are already maximally dilated as a result of local ischemia. So after CSF diversion, cerebral blood flow in white matter generally improves, as does the response to acetazolamide. So clinical features, like I mentioned before in the definition, it is the normal pressure hydrocephalus is characterized by a triad. I think something happened.
I'm sorry, Dr. Kabulo, I accidentally did that. Could you go back in the screen share? Sorry about that. Sorry about that.
Okay, can you see it now?
Yeah, I can see the screen share. I hope you can get to the appropriate slide.
Yes, I think I'm there.
I'll edit this out. Okay.
Yeah. So it's characterized by three things: gait disturbance, dementia, and urinary incontinence. So there's a mnemonic which is say wacky, wobbly, and wet. So wacky for dementia, wobbly, white gait, and wet urinary incontinence. So this develop insidiously and generally occur between the 6th and 8th decades of life. So typically gait and balance impairment appear either before or concurrently with urinary incontinence or the onset of dementia. So there is no issue of preceding intracranial event. Okay, so I'll try to go a bit deep on gait disturbance. Gait disturbances are variously described as apraxic, bradykinetic, glue-footed magnetic gait, Parkinsonian. Sometimes you can see it like a Parkinsonian, and they are typically the first presenting symptoms. So often characterized as a magnetic gait, in which feet appear to be stuck to the walking surface. So the patient will tell you that he is feeling like he has a glued foot on the thing, on the floor. So the patient is having difficulties in lifting up, initiating a movement, like making a step by elevating the foot up. So the gait may mimic a Parkinsonian gait with short shuffling steps and stoop, forward leaning posture, but there is no rigidity and no tremor like in Parkinson. So a broad-based gait may be employed by the patient in order to compensate the ataxia. I want to show you a small video of that gait. Okay. Okay, hope you are seeing my video.
Yeah, it's a video, right?
Yes.
Okay.
So this is the classic,
go ahead.
Normal pressure hydrocephalus gait before shunt placement. So this is a magnetic gait. You see the patient with short steps. Unfortunately, the video is not playing well.
Okay.
Wow.
Maybe if you reboot it again and try it, you can try it again. Reboot it, yeah. You start from the beginning. Start from the beginning, Dr. Kabulo. Maybe we'll try that and see what happens. Yeah, start from the very beginning. Okay, put it on. Let's see what happens.
Unfortunately, so.
Yeah. Oh, well, it's not. It's kind of grain. Yeah.
Okay. Then you see patient like failing to turn.
Should I share the video, Dr. Kabulo, so everyone can see?
It's okay.
Let me share it.
Okay.
Does that make sense? That makes sense. Get a better bandwidth. Great.
Is that okay?
Yes.
No.
Any comments, Dr. Cabullo?
No, it's not. I don't know if
I'm sharing the video, Dr. Cabullo.
You can see it, Dr. Cabullo. It's very clear. Can you see it, Dr. Cabullo?
Yes, I can see.
Okay. Yeah. Ulrich is sharing his video.
Yeah, the patient will be walking like that with like feet stuck on the floor. And also, if you ask the patient to turn, the patient won't make it like to turn immediately like that. He has to walk with few steps until it turns. So it will take like a long distance, 1 to 2 meters for him to turn. So thank you so much for that video, Dr. Ulrich.
Yeah, good move, Ulrich.
Thanks.
Okay. So I'm going back to my slides. Okay, so apart from gait disturbances, we have also dementia.
We're not seeing your screen, Dr. Cabullo. We're not
Can
seeing
you see
it
my
yet.
screen now?
Not yet. Not yet. Try
Can
it
you see
again.
it?
Yeah, now we can.
Yes.
Dementia.
So there is also dementia, and usually is not the presenting or most of it symptom of idiopathic normal pressure hydrocephalus. So what I think there's another voice down there. Okay, so the dementia in normal pressure hydrocephalus is a subcortical dementia. We have two types. There's a cortical dementia and subcortical dementia. The cortical dementia is the one we find in like Alzheimer's disease, in Parkinson and other diseases. So with that dementia, you get loss of cortical functions like apraxia. There will be apraxia, there will be nausea and aphasia. But in subcortical dementia, you won't have those things. So like in dementia, in normal pressure hydrocephalus, it is not associated with apraxia, agnosia, and aphasia. So then urinary incontinence, like I mentioned before, urinary incontinence and gait disturbances, they are due to stretching of the motor fibers, which are just in the periventricular. They are compressed by the enlarged ventricle. Then differential diagnosis, you have that list of differential diagnosis. These are diseases where you can also get dementia. So you have to differentiate them from normal pressure hydrocephalus. Like this table, which is showing like normal pressure hydrocephalus, Alzheimer's dementia, and Parkinson's disease. So like for age, all of them, they okay in older adults. Then symptoms, you see normal pressure hydrocephalus, you get Akim's triad. Then in Alzheimer's, you get, I don't know if you can, I'm sorry. I think it's the video I opened on YouTube.
Okay, yeah, we're still on your presentation now.
Yes.
Do you want to get off that and go on to your video? We'll give Ulrich the URL.
Can you see my presentation?
No, I can see the presentation. Not the. You wanted to show a video or?
No, there was a video. The YouTube I opened, it was still playing, so I was hearing a voice down there.
Oh, okay. Okay, you're not okay. There you are. You're back in your presentation now.
Yes. So I was saying like differences on those three pathologies where you can also find a dementia. So like I was saying, in normal pressure hydrocephalus, you get subcortical dementia, but in Alzheimer's disease, you get cortical neurological dementia. Then next, investigations. Normal pressure hydrocephalus, primarily it's clinical diagnosis. You take your history, you examine your patient, you make your diagnosis. But you can also do imaging, and imaging is essential in patients presenting with signs and symptoms. So, and imaging is just helping you to confirm the absence of subdural hematoma, absence of infection, absence of neoplasia, and other abnormalities. So neuroimaging, like CT scan and MRI are the primary mode of investigation. So in classic normal pressure hydrocephalus, on CT scan, it will show moderate to severe ventricular enlargement out of proportion to cerebral atrophy, and includes ballooned frontal horns and enlarged temporal horns without evidence of hippocampal atrophy. And the radiographic observation that best distinguishes the ventriculomegaly of normal pressure hydrocephalus from the hydrocephalus ex vacuo of advanced Alzheimer's disease is the degree of dilatation of the peri-hippocampal fissures, which are normal or only minimally dilated in normal pressure hydrocephalus and markedly dilated in Alzheimer's disease. So this is a CT scan showing normal pressure hydrocephalus. Like I was saying, you can see a balloon frontal horns. And the next one is showing the peri-hippocampal fissure. You see the picture on the right side is showing a patient with Alzheimer's disease where you get also brain atrophy. And the fissure, peri-hippocampal fissure is prominent there. But in normal pressure hydrocephalus on the left, it's almost normal. Then MRI provides additional physiologic information as compared to CT. So, because an estimate of CSF flow often can be made by using T2 weighted images. So you see area of turbulence. There will be turbulent flow in the posterior third ventricle and within the aqueduct of Sylvius, and which may increase the likelihood of shunt responsive to normal pressure hydrocephalus. So MRI sign, magnetic resonance flow imaging helps to define and characterize this flow void. So CSF flow in normal pressure hydrocephalus is hyperdynamic with an increase in the amount of velocity of CSF passing rostrally, then caudally through the cerebral aqueduct with each cardiac cycle. So this fluid movement is visualized on proton density weighted MRI as an increased flow in the cerebral aqueduct. So in the periventricular transependymal, you get periventricular transependymal CSF seepage, which I explained before. The CSF will move from the ventricle to the periventricular brain. So there are categories of idiopathic normal pressure hydrocephalus where you are saying this is a probable or it's a possible normal pressure hydrocephalus. Like according to the history, if it's probable, you get insidious onset over age of 40, but possible, you get symptoms begin earlier than 40 years. So there are differences there. I think I'll share my presentation. Everyone can go through there to see when are you suspecting it, when it is probable, when is it possible. So like on CT scan and clinically and so on. So another investigation, it's lumbar tape test. This lumbar tape test, you do your lumbar puncture on your patient with the idiopathic normal pressure hydrocephalus. You are looking for two things. One, it's opening pressure, and the second one, you have to drain a CSF. So with normal pressure hydrocephalus, pressure has to be between 4.4 to 17.6 millimeters of mercury. Others are saying from 4 to 18, which is almost the same millimeter of mercury. So you measure the pressure and you drain now your CSF, about 50 mils of CSF after measuring the pressure. So this test is not always reliable, but most commonly employed. And if now after that, before the test, before doing your lumbar puncture, you have to do neuropsychological evaluation. Then you also repeat that neuropsychological evaluation after 3 hours. 3 hours after your lumbar puncture. And the prognostic value of this procedure for identifying patients who will benefit from shunt diversion of fluid increases as greater amount of fluid are removed. So some authors have suggested that a more aggressive continuous removal of CSF on the order of 150 to 200 mils should be conducted daily for 3 to 5 days to detect better which patient may improve with shunt. So what the aim of doing this lumbar puncture is, you drain and you see if the gait disturbance will improve, if the incontinence will improve, if the dementia will improve. If the patient improves after draining the CSF, it means that patient will improve with the drainage, with the like ventriculoperitoneal shunt or lumboperitoneal shunt. So that's the aim of doing this, to see if the patient will improve with shunt or not. So like I said, a clear-cut improvement in mental status or gait predict a favorable response to shunt surgery. An improvement in gait may be seen in the form of reduced time taken to walk a fixed distance, reduced gait apraxia, and reduced freezing of gait. And the reduction in bladder hyperactivity also may be a sign of good outcome from shunting. Then you can also do a cerebrospinal fluid absorption test. This test was described by Katzmann and Hasse in 1970. So a saline infused into the lumbar subarachnoid space at the rate of 0.5 to 5 milliliters per minute produces a slow rise in CSF pressure in patients with normal absorption capacity. But when the CSF absorption is delayed, as in normal pressure hydrocephalus, the CSF pressure rises suddenly, which according to some predict good response to a shunt procedure. And in a review of 35 studies of normal pressure hydrocephalus, investigators report inconsistent result from measurement of CSF outflow pressure. Okay, next. So you can also do cysternography. Apart from cysternography, you can also do single photon emission CT scan. You can do xenon enhanced computerized tomography scan. You can also do continuous intracranial pressure monitoring. So here, it may predict the outcome of shunt surgery. And the normal pressure aspect of normal pressure hydrocephalus is something of a misnomer. What people think, like it's a misnomer calling it normal pressure hydrocephalus, because while CSF pressure may be within the normal range when measured by manometry at lumbar puncture, continuous CSF pressure measurement reveal waves of increased pressure, particularly during rapid eye movement sleep. So if you check your patient, you do continuous ICP monitoring, you realize that at some point the pressure is going up. So, which is pushing people to say normal pressure is a misnomer because there is increased pressure. So in terms of management, the normal pressure hydrocephalus can be a reversible or treatment disorder. You can give acetazolamide, 250 to 500 milligrams per day to decrease CSF production. And the anecdotal reports suggest that levodopa and carbidopa are of benefit in patients with normal pressure hydrocephalus. So depression may be benefited with antidepressant. And This is an algorithm showing, just summarizing what I explained. What you do, you get your patient. On the left side, we have the degree of certainty of improvement sensitivity. So you get your patient clinically. I said the diagnosis is clinical. You take your history, you examine your patient, you make your diagnosis, clinical diagnosis. Then you check, is there a triad? Is there a triad? Akim's triad: gait disturbance, urinary incontinence, and dementia. If the triad is there, then you evaluate surgical candidacy. If there is no triad, then you follow your patient. Then clinically, once you get your triad, you go now and do neuroimaging. If you do neuroimaging, there is a ventriculomegaly and the Evans index is greater than 0.3, then you evaluate surgical candidates. But if there is no ventriculomegaly and the Evans index is less than that, you follow up your patient. Now, evaluating now the surgical candidacy, if you do now the lumbar puncture test we mentioned, you do that lumbar puncture. If CSF is greater than, if ICP is greater than 18 millimeters of mercury, then you look for other probable causes, probable secondary hydrocephalus. But if CSF pressure is between 5 and 18, then you do CSF dynamic test. But if it's there is high pressure with and the patient is improving with draining of CSF, you go straight and put your VP shunt. So this is just an algorithm showing if the pressure, for example, is between 5 and 18, then you do your drainage protocol. Doing the drainage protocol, if the pressure is normal and the patient not improving, the drainage protocol is negative, you follow up the patient. If the drainage protocol is positive, you go and put the shunt. Now, cerebrospinal fluid drainage through a VP shunt or ventricular arterial shunt gives good result and is universally accepted. Now, the shunt they use in normal pressure hydrocephalus, it's low pressure shunt. We have 3 types of shunt: high pressure shunt, medium pressure shunt, and low pressure shunt. The high pressure shunt, we put it in obstructive hydrocephalus when the pressure is too high. So usually people confuse the high pressure. They think like high pressure, it means it is draining with the high pressure. No, high pressure, it means it only drains when the pressure goes up. When the pressure is high, then the shunt drains. If the pressure is normal, the shunt won't drain. But in normal pressure hydrocephalus, there is normal pressure. So we use the low pressure. Low pressure shunt, it's like a drain, just draining your CSF. Now, with low pressure, it can drain even when the pressure is 5. The low pressure can drain. Now, in a Dutch hydrocephalus study, the authors noted that the best results were found in the subject treated with low pressure valves. Unfortunately, they also provide the greatest number of subdural fluid accumulations. This is one of the complications of VP shunt. Like I wanted to comment also on Zolo's presentation. This is a very frequent complication. After putting your VP shunt, especially the low pressure, you overdrain. Then the brain is like detaching to the meninges. You might get an epidural. You might get usually it's a subdural hematoma for overdrainage. Then the use of a adjustable valve seems to be beneficial in the normal pressure, in the management of idiopathic normal pressure hydrocephalus. So there is also a siphon control device which was introduced. It was incorporated in the treatment of this patient since 1991, and newer valves with protected siphon control device have brought more possibilities to manage these patients. And there is no role. Okay, others are saying cortical biopsy is debated. It's debatable. Then a high prevalence of cerebrovascular disease and Alzheimer's disease has been found in patients shunted for idiopathic normal pressure hydrocephalus. So these are factors to predict shunt responsiveness, like I mentioned again before. Then, okay, my take-home message, I just summarized everything in those few lines. So the idiopathic normal pressure hydrocephalus is a syndrome characterized by gait impairment, cognitive decline, and urinary incontinence, and associated with ventriculomegaly in the absence of elevated CSF pressure. Pathogenesis is not understood. Intermittent intracranial pressure, decreased CSF absorption, and cerebral ischemia have been blamed. And the hallmark of neuroimaging in normal pressure hydrocephalus is ventriculomegaly out of proportion with sulcal atrophy. MRI is the choice of imaging. CSF flow in NPH is hyperdynamic with an increase in the amount and velocity of CSF passing rostrally, then caudally through the cerebral aqueduct with each cardiac cycle. Clinical improvement after CSF drainage implies good response to shunting, and the best results are found in the subject treated with low pressure valves. Increased use of adjustable valve seems to be beneficial, and gait is most likely to improve. Post-operative reduction in ventriculomegaly is not always seen on proportionate to the clinical improvement. Thank you for your understanding.
Thank you very much.
Thank you very much, Dr. Gabulo, and thanks everyone for coming. You're turning into the mentor of this group, Dr. Gabulo.
Thank you so much, Dr. Benedetto. Thank you, Nuru.
Thank you, Dr.
John, it's not turning into.
I have some comment.
Go ahead, Nuru.
Thank you, Dr. Kablo, for your great presentation, and it is so clear. I just want to comment to make some. All of them have to pay attention about our patient, about the clinical. It is important to do good clinical examination, physical examination about our patient to know well our semiology in neurology. Because if you don't do the diagnosis with this triad about Adam and Hakim's, you will you can do the diagnosis, because you will think maybe it is dementia or it is another disorder. It is important to pay attention about this triad, and also to go to do CT scan. And sometimes before to do CT scan, you can do this test that we usually do in our constellation to try to done puncture lumbar and to remove and to adapt the tubular to done one measure of pressure to see if we are under 20 centimeter or low down 20 centimeter to know that yes, we are in normal pressure. We are in normal pressure, but with this triad, you have to go to do CT scan to measure our index, our Evans index, and also don't forget that always when you put some people in acetazolamide drugs, don't forget to give them potassium, because acetazolamide should be complication like hypokalemia. So you have to pay attention always when we give acetazolamide for a patient. We have to add potassium, and of course, yes, it is. I think it's better to put nowadays normal pressure in normal valve pressure in ENPH, hydrocephalus to treat when we are according about the treatment. It will be shunt. So we have to put normal valve pressure, because it is not all of our person who have money to buy adjustable valve. So that is my comment, and thank you, Dr. Kablo. I think all you say all about that since the history to nowadays. So great presentation, and thank you for your contribution about the lecture.
Thank you so much, Dr. Nuru.
Okay, Ulrich, you had something to say to Dr. Kabula?
I mean, it was just to thank Dr. Kabulo. You said he was becoming a mentor. He's been a mentor for quite a while. Him and Dr. Nuru have been with us for a while now. So it's not now that they're becoming mentors. When you don't see them, then they're probably busy in the operating room, but they're always there.
Great.
They're always, yeah.
Great. They're always welcome. Any
Dr.
other comment?
Want to say something?
Go ahead. Go ahead, Kelvin. Let me unmute you. Kelvin.
Unmute yourself, Dr. Kelvin. Yeah.
There we go. Okay, go ahead.
Okay.
Kelvin.
Okay, you can hear me now?
Yes.
Fine. Thank you so much, Dr. Kabulo, for the fantastic presentation. I think you touched on all the most important aspects. It was a job well done. Excellent. Keep it up.
Thank you. Any comments, Abdullah?
Congratulations.
Go ahead, Abdullah.
Well prepared, and he actually delivered it well. Well done, well done. You've touched on most aspects of the disease actually, on a practical point of view. Well done.
Okay. Abdullah, we'd like to have you do some presentations too. We'd like to have you do some presentations also sometime in the future.
Yeah, but sometimes in the future, I will be willing to do
Sure,
that.
whenever you have time. That's fine.
Oh, all right.
I like something you do, Kabulo. It is your key point. It is very, very useful, and I screen that and to share that with my colleagues. Your key point is very useful, and when you show this diagram about to take decision, was useful also. So great work, and well done.
Thank you, dear Nuru.
Okay, any more comments and questions for the audience from the rest of the panelists? Zolo,
Hey,
Seville?
John.
Go ahead, Zolo.
No, it's Dylan.
Okay, go ahead, Dylan.
It was just to congratulate Dr. Kabulo. It's like Sydney said, he's really been a mentor for us this time. So, and it was really a great presentation. I really appreciated it. It was clear. Congratulations, Dr. Kabulo.
Thank you so much, Dr. Dylan.
You know, this is great, Dr. Kabulo. Medical students are getting lectures like this early because it's a topic that a neurosurgeon has to know cold, has to know very well. And it doesn't hurt to repeat. So I'm sure they'll hear about hydrocephalus the rest of their careers. So you might as well learn it early. Words of wisdom.
Also, I want to say something. Also, you have to pay attention about idiopathic hydrocephalus. But in this case, it's not normal pressure. And you also, it is common in women with obesity sometimes, and the essential sign who catch our attention is loss of vision. It is a disorder of vision. So you can do the difference, and also it is in young population. You will find that. That's named also idiopathic hydrocephalus, but normal. Please, it is hydrocephalus. Pardon, please. It is idiopathic hypertension intracranial. Yes. So in this case, you will see a rise about the intracranial pressure. About the when you will done a test of CSF, you will have the CSF can take like I don't know 50 centimeters when you done measure of pressure. So it is also idiopathic because the physiopathology is not known nowadays. You have MRI, it is normal, but you have lost vision, you have hypertension, rise of intracranial pressure. So it's just a comment.
Thank you, Dr. Nuro.
That is, sorry, in response to Dr. Bankule's comment, that is, I think is called benign intracranial hypertension or slit ventricle syndrome. It has a lot of names. As you said, it's
exactly. Yes.
Young confusion. But clinically, yes, you might think of that, but considering the age group of normal pressure hydrocephalus, which is usually approaching the elderly age group, those are usually population. Then when it comes to image, is really you can get the difference, because obviously in the elderly one, the normal pressure hydrocephalus, there is atrophy, of course, and there is ventricular dilatation, while in the benign intracranial hypertension, of course, there is associated what looks like, in fact, a tight brain, brain edema.
Ventricle. Yes.
Yes. Exactly. But as you said, it's good to consider it while evaluating the patient clinically, but investigation actually puts them apart. You can easily see the difference already.
Exactly. Good. And if you take CT scan, you will see that your ventricle is so slight. That's why in this case, sometimes we just perform lumbar shunt. You can't do ventricle VP shunt. You just perform lumbar shunt, because in this case, your ventricle is so slight. So you perform lumbar shunt, lumbar peritoneal shunt in this case.
Right.
Good.
John, your mic is muted.
Okay, yeah. Any more comments or questions from the panelists before we terminate? Okay, I'd like to thank all the panelists for coming, especially the newcomers, Abdullah, Cyril, I think you've been here before, and Kelvin. You're welcome to participate in any of the conferences, and you can see what these kids are doing. They're pushing the tech with Zolo and Dewen, you know, not the greatest bandwidth from their smartphones, but yet they're producing quality education videos in neurosurgery. And we hope everyone continues to follow along. So I'm going to post this. It'll be edited by tomorrow night, and you'll have separate presentations. And I'll also invite you. I want to share. We have a webcast tomorrow with Cherian, and you're all invited to attend. It's at 5 o'clock India time, which I believe it's 1:30 in the afternoon in Cameroon, and the Eastern Standard Time for Ulrich it's 7:30 a.m. We have two presentations. He's going to talk about recurrent voice loss in a 40-year-old male, and also MCA aneurysms. So you're all welcome to come to that. And okay, I bid adieu from Miami.
Okay, good.
Okay, very good.
He missed Dr. Sherian. It is so long time we don't do Super Sundays.
Okay, well, yeah, well, can you come tomorrow, Nuru, you think? 1:30?
Yes, I will. Yes, I will attend. Well, I met him in Beijing last month. I met him. Sherian.
Oh, okay.
He was the chairman of Cysternostomy Symposium. Symposium.
Well, he likes interaction. When you go there, he'll like it if you interact. He likes it for the panelists to become involved with the discussion. So you'll have your opportunity to do that. And Abdullah.
I'm sorry, guys. All this time I don't come every time because I was so busy with.
Well, that's okay. We understand.
Senior, it's very difficult. So I'm sorry to don't attend regular usually and all this. So, but I will try to come back. So don't worry. I think I have presentation in 2 November. In 2 November, I think I have presentation from I think about spontaneous hemorrhage and intraparenchymal. I think I will prepare that. I'm on it.
No, we
And,
appreciate you coming at all.
Maybe we will. We have. I don't know, Ulrich, if you will be at Kinshasa. Maybe we can televise the 5 November discourse about the research in Africa.
Yeah, I think we are televising.
Try to televise that.
Well, let me show you what we're going to televise from Africa and from Tanzania, I believe. Hold on. Dr. Juma Magogo wrote me this morning and said he wanted to televise a conference from Tanzania. He's running it.
Okay.
Oh, hold on. This I guess another one.
Ulrich, you are there?
I think he stepped away.
Not there.
I think he stepped away.
Yeah.
Hold on.
Yes,
Let me get. Oh, okay. Here it is. I'm opening it now. Okay. Yeah. Okay. Great. Here's what we're going to be televising, and besides the one you talked about.
Okay.
Are you familiar with this one? 11th to 15th of November from Tanzania.
Oh, okay. Great.
Okay, we're going to be televising that. I think we're going to be televising Kenya also. There's a couple of conferences in Kenya. I think there's one in March and there's one in the summertime.
Nice.
But we'll be televising, and this will be interactive. You know, we'll probably be televising the live surgery, as well as the other lectures. So Juma, one of the organizers, is a big user of this platform. He did a fellowship in India. He's from Tanzania originally, but he's an active member of this platform.
Okay. Good.
Okay.
Good. Okay. Thank you, John. And
okay. Thank you, Naru. We'll be edited by tomorrow. It'll be out there tomorrow.
Yes, I will. We will see you tomorrow with Great Super Sunday with IP Chirian. See you tomorrow.
Very good. Yeah, welcome.
And next weekend, everyone. And see you soon. Bye-bye.
Okay, bye-bye, Naru. Cyril, are you there? Can you hold on, Zolo? I'll talk to you in a minute. Cyril, are you there? Let me try and mute you, Cyril. Are you there, Cyril?
Yes, I'm there.
Okay, we can't get your video's not on there. You gotta turn on your camera so we can meet you. There you go. There you go. How you doing, Cyril?
Hi.
It's better to associate a face when you meet somebody.
Okay.
Now, where are you from, Cyril?
I'm from Cameroon.
I'm sorry?
I'm from Cameroon.
Oh, okay. Okay.
Yes.
Very good. Maybe Zolo will explain where is that at? My geography is terrible.
She said she's from Cameroon.
Oh, Cameroon.
I'm
Okay.
from Cameroon.
Oh, okay. I'm sorry. I didn't understand.
Okay.
We did an ENT console, I think.
Cyril, how are you, Olivia?
I'm fine. And you, doctor?
I'm okay.
Okay. Very good presentation. I appreciate it.
And so, Cyril, do you know Dr. Gabulo? Have you met him yet?
Yes, we know each other.
Oh, okay. Very good. And Kelvin?
We know
Kelvin stepped away, I think.
No, I'm around.
Oh, there you go, Kelvin. Have you met Kelvin yet? Kelvin's from Zimbabwe, a neurosurgeon but he's currently in Turkey, correct?
Yes.
Okay.
How are you, my dear?
Nice to meet you, Dr. Kelvin.
Nice to meet you too, Cyril. Thank you.
Okay.
How is Cameroon?
Cameroon is good.
Very good, very good. Let's keep working together.
Okay, I'm waiting for you.
Yeah, I think you've been here before, Cyril, right? You came to a presentation before.
She did medical school in DRC, in Congo.
Ah, very good.
Yes.
Okay, thanks.
Very good.
Yeah, it's well, it's good to have all you here. This group is slowly growing. Slowly.
Yeah, sure.
Slowly growing. Then we'll add people because the presentations are just as good as anywhere I've seen in the world. Africa does have nothing to be ashamed of. The quality of presentations is just as good as anywhere that I've seen, including America, because basic science is basic science. You know, a good lecture in basic science is a good lecture. It doesn't matter where it's from.
Absolutely correct, Dr. Bennett.
Yeah, and Zolo, the way Zolo, his presentations, man, they're excellent. It's top of the art, top of the state of the art, Zolo.
Zolo, my friend, thank you so much. I was following your presentation on YouTube. It was great. Thank you.
Oh, thank you.
Yes, it was okay. I was following on YouTube. I wasn't on the panel, but I was seeing it on YouTube. Yes.
Thank you.
Well done, the indomitable lion.
Yes.
What is that? Is that the soccer team?
Zolo is a nice smile. I always like to see him smiling.
Oh yeah, he's got a great smile.
Thank you.
That's good. We gotta get great internet for Zolo. Or better internet. We'll talk about that later. So
okay, Dr. Bennett, thank you so much.
Dr. Cabullo, thank you. I'll send you the copies tomorrow of all the videos, all three.
Thank you, everyone. My boss, Kelvin. Respect.
Thank you so much. Thank you, everybody.
Okay.
Thank you.
See you, Dr. Cabullo.
Thank you, Olivia.
Okay, you know, Zolo, is there only a, yeah, Kelvin, we're trying to figure out how Zolo can get better internet. Zolo, is there a company, what company supplies you with internet? What's the name of the company?
The actual.
Can we go to their website? We go to their website? We're just going to try to figure out, Kelvin, how to get Zolo better internet. Your audio, I can't get your audio there, Zolo. See. And Zolo his internet seems to be worse than most. So we're going to try to figure out a way we can improve it because he has quality presentations. And I hate to have audio problems and bandwidth problems during his presentation. Zolo, okay, can you hear me okay? Zolo, can you hear me? I can't hear you. I can't hear you. I can't hear you. I can't hear. No audio. No audio. Cannot hear. See, these are the problems you get, Kelvin. Internet will freeze. Hello, Zolo, you there? Can you hear me okay? I can't, your sound is off. Your microphone. No. I can't hear. You can hear me? I cannot hear you. Yeah, we're trying to figure this. I guess, Kelvin, your screen is frozen too. Zolo? Oh, okay. Okay, you can hear me, Zolo. Okay, please write your name